Good afternoon, everybody. Thank you very much, panelists, chairman, Professor Abdullah Shahab, for the opportunity. It's a pleasure to be here. I'll try to be quick since the time is scale. I have no disclosure regarding this presentation. I mean, we all do what we do now due to this professor in 1929 who did the first angiogram on himself, Professor Frostman, and we're just capitalizing and keep evolving. Now, this is a famous say, and I believe in it, for Professor Thomas Huxley, saying the deepest sin against the human mind is to believe things without evidence. So we're gonna believe in evidence first. And I think we've heard over the last 3 days a lot of talks about DCB as they emerging into probably the field of intervention. And just a comment for Dr. Ziad, there is a group of consultants in Salford, in the UK, they've been doing primary PCI with a pure DCB, with angiogram next day. They published some data. They've been doing it for the last 15 years, and their event rate is as low as DAS. I think this is something to look into it. I didn't include it in my talk, but this is something for the future. I think perhaps DCB might be the option. We've all seen this landmark publication, The Lancet recently, talking about drug-coated balloon, angioplasty, rescue stenting versus indeed. So the expansion of DCB is happening and occurring on the last perhaps couple of years. Now, I thought I'll show you just a quick case, and we will have a quick discussion, a raise of hands, as what to do next. This is a 74-year-old male, full house of risk factors, had TAVI sapien 223 in 2017 for severe aortic stenosis, presented in September 2020 with acute coronary syndrome positive troponin. He was on single PY12, and his echo demonstrated mild left ventricular systolic impairment with ejection fraction 46%, and aortic valve was perfectly fine with acceptable gradient. This is the first picture. As you can see, his right coronary artery densely calcified, with tight focal stenosis. So the plan was basically to do some drilling, atherectomy, prior to the final device. You can see we did some 1.5 drill across. It was straightforward. IVUS, which for some reason couldn't play it at the faculty center, but at this point, I'll show you this is the final outcome. Now, I won't tell you whether there is stent or not, probably you can tell, but this is one, remember, 2020. And at that time, stent was straightforward answer at this stage. However, thinking about it right now, I think it's something for discussion. And I want, just in a raise of hands, who would have put DCB in this patient instead of me stenting the mid-RCA? In a show of hands. So not bad numbers. Excellent. Now, I will just touch upon, he's had the same story in his LAD, which we drilled atherectomy with a stent, and the results were satisfactory. Patient attended, I think, a couple of years afterwards, his angiogram was satisfactory. So just before jumping to conclusion, I just want to show this publication in JACC Asia, showing what they do currently in China in terms of optimal lesion, in terms of drug-coated balloon-based treatment approach for coronary artery disease, which is quite a radical change in general what we do. So the idea is the crucial part is optimal lesion preparation, and I think it's key for any lesion we do, whether it's atherectomy, laser, whichever it's required, needs to be done. Indeed, intravascular ultrasound or imaging is key before any final device. And as you can see, their results and recommendation were quite It's quite impressive. And you can look at tough lesions such as chronic total occlusion. They still argue that DCP might be an option for us as a final treatment. Without further delay, I think as a take-home message, DCP is gaining huge ground on DAS, and I'm a big believer, particularly in acute coronary syndrome lesions, specifically ST elevation, MI, intravascular imaging, maybe DCB, re-angio next day with imaging, intravascular imaging, might be the ultimate treatment without leaving any inflammatory triggering metal inside the arteries. That's something for large randomized controlled trials. And thank you very much.